Good afternoon. This webinar is funded through the California Institute for Behavioral Health Solutions KDA webinar series. The project is funded through a Department of Healthcare Services contract, and additional technical assistance and support was provided by Lisa Molinar and Rich Weisgal of Shared Vision Consultants. Today's webinar is Implementing KDA Through Collaborative Decision-Making, Small County Perspectives, Part 1. We're focusing today's webinar on our next one on June 30th on small county implementation of KDA Pathways to Wellbeing, because we know small counties bring a certain perspective that's really different than from a larger county or a medium county. So before we begin today's presentation, we have 3 polling questions we'd like you to answer, and this helps us to get a better understanding of who you are. So first of all, tell us where you work. Do you work in state, county, or child welfare, state, county, behavioral or mental health, contract agency or CBO providing services, education and training organization, or others? Go ahead and submit your answers to that. And people are voting. Okay, we're going to close the poll in a minute. Okay. So we have 20% are state or county child welfare, 52% are state or county behavioral mental health, 13% are contract agencies or CBO providers, 7% are education and training organizations, and 9% for other. Great, thank you. All right, we're going to go back to our slides now. Also, let's tell us the nature of your work. Do you work directly with children and families? Are you a supervisor or a manager? Are you a family partner or youth peer provider? Are you a consultant, trainer, or a TA provider, or other? Go ahead and respond to our poll. All right, almost everybody has voted. Okay, we're going to go ahead and close the poll in just a minute. Okay, we'll close the poll. So we have 37% of you work directly with children and families. 33% are supervisors or managers. 2% are family partners or youth or peer providers. 9% are a consultant, trainer, or a TA provider, and 19% are other. Great, thank you for responding. That really helps us. Okay, so we'll go back to the slides. And the final polling question we have is, how would you rate your county's cross-agency collaboration with regard to KDA implementation? Strong, average, or still developing our collaboration? And this is our final polling question. And we're going to close the polls in just a moment here. Okay, we'll go ahead and close the polls. And we have 34% of you feel your collaboration is strong, 32% are average, and 34% are still developing your collaboration. So that's good. We have a pretty even mix across the ranges. Thank you. Okay, so now we're going to turn to our presentation. We're going to hear today from Napa County, we're going to hear from Kings County, and then we're going to have some questions and answer periods. So, first of all, we're going to start with our Napa County presenters, which is Chelsea Stoner. Chelsea Stoner currently supervises Napa County's SB 163 Wraparound Program and Continuing Services Unit of Child Welfare Services. Her previous experience in child welfare includes continuing services, dependency investigations, wraparound, independent living skills, and extended foster care. She's been a part of the KDA implementation team since January 2014, working in partnership with Napa County Children's Mental Health and Napa County Juvenile Probation as the Pathways to Wellbeing program has developed. She truly enjoys the collaboration that KDA calls for to ensure our children and youth continue to get the services that they need. Colleen Paul became the supervisor of Napa County's KDA Services Program in August 2014, which is now named the Pathways to Wellbeing Program. She's a licensed marriage and family therapist, a licensed professional clinical counselor, a registered art therapist, and has a certificate in infant parent mental health. She's worked in mental health for over 15 years in a variety of settings, with the last 6 years at Napa County. Colleen has also worked in the past for child welfare doing emergency response and adoptions. And over the past several months, she has worked in collaboration with Napa County Child Welfare and Napa County Juvenile Probation to get this program up and running, and feels very lucky to work with Chelsea in the process. So I'm going to turn this over to Napa and to Chelsea and Colleen. Go ahead.
Hi, this is Colleen.
And this is Chelsea.
Great. So I wanted to start by talking about our learning objectives. So if we could have the next slide. Great. So these are the objectives. This is what we hope you get out of our discussion. So basically to learn about our efforts to meet KDA services mandates, and to learn from our experience creating our program and encouraging our collaboration between mental health, child welfare, as well as juvenile probation. And then hopefully you'll get some ideas from what we've done and hear some possible solutions to maybe challenges that you have encountered as well. Just real quick, I just want to say I started a little bit later in the process than Chelsea. So Chelsea's going to talk a lot about the history and what led up to where we are now. So I'll turn it over to Chelsea.
Great, thanks, Colleen. Next slide, please. So we want to talk with you a little bit about life before KDA here in Napa County. And while we had some multidisciplinary meetings and shared the same building, CWS and mental health were two very separate divisions. We didn't always collaborate well, and we didn't always have the best mechanisms to successfully communicate, which sometimes led to some conflicts. Next slide, please. So in thinking about life before KDA, what was happening for our county is we didn't really understand each other's functions. We had variations on interpreting what the parameters of confidentiality are and were, and what can and cannot be shared, and this sometimes created conflicts between our two divisions. Mental health was often unclear on the services provided by child welfare. For example, it would be like not knowing the difference between court-mandated services and voluntary services, who had signing rights, and who should be involved in therapy, birth parents, foster parents, both. There was also not a clear understanding of the services offered through mental health and how to access them. We also didn't really have a clear referral process and limited protocols for collaboration. We did have a system of care collaborative model that was created for the SB 163 wraparound program, and while there were some other multidisciplinary meetings, they may not have always worked well to improve communication. And services in mental health from the child welfare perspective were really word of mouth. Social workers were unclear who did what in mental health, and we would typically refer clients to clinicians that we knew rather than specific programs or services. So for example, if I knew that Colleen did really great play therapy, I would just contact her directly rather than go through any sort of referral process, so mental health would know who was referring for what. But on the other hand, an area of improvement that we did see in 2012 was a pilot project that embedded a mental health clinician in child welfare services. And this clinician conducted universal mental health screenings for every child who entered foster care and actually shared office space with the social workers. The clinician was able to provide screenings. She was able to collaborate with social workers in real time regarding mental health issues for children in foster care and provide mental health advice and expertise. And this was extremely helpful in terms of collaboration. Next slide, please. So in 2013, Napa County began the implementation process for KDA. We identified champions from various agencies and divisions for this effort, and we contracted with our former Deputy Director of Health and Human Services to provide consultation in this project, as he was an expert in our agency and the inner workings of it. We had an oversight committee, which was called the Wellbeing Initiative Leadership Team, and that consisted of our child welfare director, our mental health director, the chief of probation, and we would occasionally bring in ad hoc members like fiscal or ITS as needed. And we also developed a KDA work group, which was like a steering committee, and with supervisors of various programs that would meet biweekly to sort out how to determine subclass and determine our programming. Next slide, please. Before we go any further about our program specifically, we want to talk with you a little bit about our philosophy here in Napa County regarding how we approach serving children in foster care. As a general principle, we view all children in foster care, regardless of which system they're in, child welfare or juvenile probation, as a shared responsibility. In a county that's so small like Napa, kids in foster care are often served by both systems at one time of their lives or another, and they often have mental health diagnoses. So we truly believe that partnering together leads to better outcomes for our foster youth. So when we began our development of KDA programming, it was natural for juvenile probation to be sitting side by side with child welfare and with mental health. We also have a strong belief that youth voice is important in our program development, as well as caregiver involvement, and we decided that the best way to get their voice in the room was to hold focus groups. So in June of 2013, to help us know what was really working and not working in our systems and how we collaborate with one another, we held 4 different focus groups. The first one was supervisors and managers of child welfare, mental health, and probation. The second focus group was for youth, and we had it held at our local youth center called Voices. And we provided youth with incentives. We gave them gift cards to Target, as well as gave them dinner to help get them to the table, because we all know that youth sometimes need some encouragement. We had a caregiver focus group as well, and we held that at the same time as the youth focus group. And we provided the caregivers with child care, so they didn't have to worry about finding a babysitter for their kids in foster care. And we also gave them dinner. And finally, we had a focus group of line staff from child welfare, juvenile probation, and mental health. They were also given lunch as well, which they were very happy to receive. From these focus groups, we, next slide please. From these focus groups, we found the strengths of Napa and the challenges of Napa, none of which were surprising to us, but it really outlined what our community was saying was working and not working in terms of our collaboration in mental health. Some of the strengths that we saw as a theme was that all kids in entering foster care were receiving a universal mental health screening. It was also determined that therapeutic behavioral services, as well as wraparound services, are strong in our community. Our community-based organizations are committed to improving mental health services to youth and supporting our youth in care. And parents felt support from attending therapy and from the mental health therapist. But some of the challenges that we saw included what we already knew, that there was a lack of understanding regarding the parameters of confidentiality between mental health, child welfare, and juvenile probation, and this created conflicts regarding sharing of information, and that information that was shared was not always consistent from provider to provider. There was also a hierarchy and approval process of getting mental health services, and that was not always timely, and it could be a barrier to obtaining services. There was a high turnover in staff in all of our agencies, and we had a lack of Spanish-speaking services for youth and families. So we took that information and used it to develop a foundation for KDA programming, which led to the creation of our current Pathways to Wellbeing program. And I'm going to turn this over to Colleen to talk more in depth about where we are currently.
Okay, so next slide, please. So one of the things that happened is we pretty much found that we were living the CFT, and so we were kind of creating our program with many of the values and the principles that are provided in the core practice manual. And so we just kind of laid that out. So we started with the building of the team. As Chelsea already mentioned, we did hire a consultant to help us with that process. So in many ways, he was the facilitator for that process, and he was pretty neutral, although he knew us all very well. So that was incredibly helpful. We also he also really encouraged the development of a mutual agreement and a commitment from everybody on the team to really work together. And in that process, people were able to come to the table, and he invited everybody, all the partners. So that's child welfare, juvenile probation, mental health, but also the ancillary people involved. So that would be like our fiscal division and IT, and in our case, it's Anasazi, which is our database. So they brought these people all to the table because what we were doing would affect everybody, and we needed everybody's input. Another thing that was really positive is that through his facilitation, I believe he was able to establish a really open forum for discussion and honest communication about what we were doing, what we needed, and where the challenges were. And everyone at the table had a voice, so that was reinforced. And so as we developed the common goals, we were able to ID the needs of each system, and as well as the needs for the youth and families involved. But we didn't necessarily have youth and families at the table during this process, and that's an area that we will continue to expand upon. We also were able to look at how each system's functions, learn from each other, how they did work, and how people could adapt to possibly meet the mandate. So those are part of the discussion that we had to come up with the common goals. And the overall goal was to build a program that really met the needs of the youth and the families that we serve. Then we moved into our plan development phase, which is where we were really taking those goals and figuring out how to implement those goals. So there was a lot of specific program development at this point. Looking at, in many ways, like you do a CFT, we would look at who would do what and when they would do it by. So who's following pretty much that structure in terms of what needed to happen, who would do it, and really coming back to the group and reporting out on what had happened. We also used our group to really vet any ideas that came up, and so we were able to discuss everything, including documents that we use, the name of the program, things like that. And then testing practices and tweaking, that's where we're at now. So we are actually implementing the program. We're meeting less frequently, kind of like the CFT builds towards you don't need them as often, so we're in that phase. We're reviewing our progress and looking at challenges, new challenges, as well as things that continue to be challenging. And we're adapting the program as we go to be more effective. And then, of course, we'll move into our next phase, transition. That's our goal. We're headed that way. So much like the CFT, that's how we've been really trying to do that. Next slide. So one of the things that, well, we had a new clinical director come on in December, and one of the things that he helped was gave us this time frame so we could kind of map out many of the tasks and give us some target dates. So I just threw this in, or actually Chelsea threw this in. So it would be an example of one of the ways that we sort of tried to organize and figure out how to move forward and kind of cross things off as we went along. Next slide, please. So program design. So basically, as we've already kind of said, it's really a steering committee driven process, and it has representatives from all the partners that we identified that needed to be in this process, and also brought in all the perspectives from the various partners that are involved. We looked at determining the subclass, which for us has been a little bit challenging. We've been scrambling every 6 months to do our 6-month report. So one of the things we really wanted to do was create a simplified way to do this. So when we simplified the form that we used to identify eligibility, and that actually is one of the handouts that is included. I will say that I want to thank the KDA toolbox. That has been amazingly helpful, and I also have to shout out to San Diego for their Pathways to Wellbeing information. They were very helpful to us in this. But anyway, so we did want to simplify how we were looking at eligibility, and also we created a system for how we would do that on a regular basis with child welfare and probation, so that we would keep current on the list. So at this point, Chelsea and I meet monthly to review the kids that we've identified as subclass members, so we know who's still subclass, whose cases have been dismissed, what situations have changed, or who's doing better and can be moved on to lesser intense services. We also work together to create a workflow for that eligibility and referrals. Ken already said that. We have a flow chart in the next slide, but I'll just finish this slide. We've been working on CFTs and defining the roles of the Pathways to Wellbeing staff and the expectations for each of the members of that child-family team meeting. This is a process that continues to go on. And also the bringing in the probation youth, since there's some different aspects to that, we're continuing to work on the development on this part of the program, particularly just making their workflow in terms of referral and eligibility more effective. So the next slide, please. So here's an example. So we worked together in the steering committee to develop this workflow, and our mental health analyst, Sandy Schmidt, put this together. And so it's complicated, but it was organized in its own special way. So anyways, you can kind of see how we define some of the roles and the tasks and the practices. And then on the right side, you'll see there's some cloudy areas, and those are the ones we're not really sure yet how we interface with them, but they do also have subclass members. I'm sure other counties experience that, but so we're trying to figure out how we bring those into the system as well. Next slide, please. I'm trying to think. Okay, so obviously this is life since we've implemented KDA. Perfectly coordinated. Anyway, so where we are now, you can show the next slide. So now we have the Pathways to Wellbeing program, and it consists of myself as the supervisor, and we currently have one full-time staff who carries a caseload, and he's working with both child welfare and probation youth and their families or their foster families. And then fortunately we have two full-time staff who have been hired and will be starting in the next 2 weeks, and both of them are Spanish speaking, so we're really excited to be able to offer the bilingual services that are needed. It took us a little while to get the full staff, so that was one of the issues we encountered. Another thing is we're working on expanding our training so that we can increase the Pathways to Wellbeing staff skills and their ability to implement the core practice manual, and particularly around facilitation for the child-family team meetings, teaming and engagement in general. And the steering committee now, we just met yesterday, we're meeting monthly and more focused on some of the work agreements that we've created. We had worked on a memorandum of understanding related to our eligibility and referral process, and the next step is we're going to be working on the agreements of information sharing. So we'll be tackling that next. And then the program design is constantly being re-examined to see if it's effective, so we're identifying areas where we need to do some better work. There's still some time delay issues, and also still some need to clarify roles and what exactly we do or don't do. And that's just all part of the process, I think, as we move forward. Next slide, please. So one of the areas that we are looking at is how do we do this with mental health, because we had taken on cases where there was already a mental health case manager and they were already receiving mental health services in our mental health department. But we, as the Pathways to Wellbeing staff, came in and started taking on more of the facilitation of the CFTs and the ICC role in that. So we're still trying to work all that out in terms of like whether everybody should have their own mental health case manager. I'm not sure how it is for other counties, but we do have a lot of kids that receive their therapy services either with an independent provider or through another agency. We have other agencies that serve this population. So we're still working on really clarifying the role of the Pathways to Wellbeing staff and what it really means to be the ICC coordinator. We had to look at our IHBS services and whether or not we could actually provide the level of intensity that was necessary. So the group really agreed on a plan to contract with Sunny Hills, their contractor, who do our therapeutic behavioral services, and so we've added them to do our IHBS services as well. And again, we have a monthly meeting for mental health and child welfare leadership. They meet and discuss issues that arise, not just from the Pathways to Wellbeing program, but also in general. There's a lot of issues being identified about our overall collaboration above and beyond just the Pathways to Wellbeing. So what's been nice about this whole process is that it's helping us collaborate more effectively overall, both with child welfare and with probation, as we get to know more about, the areas where there's obstacles, and also learning from each other in terms of what our cultures are like, what we can and can't share in terms of information, where those glitches in our communication are, And a lot of times these do center around specific cases and issues that arise as we encounter them. And we'll bring them to this monthly meeting and discuss them together as a group to try to find resolution. Okay, so next slide, Chelsea's going to lead our discussion on lessons learned, which are many.
Which are many and evolving all the time. In thinking about the successes that we've accomplished in the past couple of years, we really are excited that CFTs are happening. It's been a long process to get them up and going, and they're happening. And billing has been going on since March. So DHCS is happy with us. Also, in 2016, our Health and Human Services will be relocated to another location, and that will allow the Pathways to Wellbeing to be embedded in child welfare services. So again, we will have that access to mental health clinicians and experts a lot more readily than we do now. And we are all increasing our knowledge and understanding of the core practice model and how it interfaces with both child welfare and probation and mental health. Some challenges that we faced recently is we've had some leadership changes in mental health and child welfare, and it's not really a challenge, it's just a change that we are undertaking. And staffing for Pathways to Wellbeing has been also a challenge. We've had one staff in the Pathways to Wellbeing program for the past few months, and he's had a full caseload, so we're really looking forward to having 2 new staff start in the next couple weeks. So for some solutions, our next steps are really to bring our leadership up to speed about where we are and where we're going and get their input and direction. We'll be doing a lot of cross-training with child welfare, mental health, and juvenile probation, and visiting each other's specific unit meetings to not only model what collaboration is, but also to talk about the program and what expectations are. And outside consultants will be coming in to give us some trainings on KDA and collaboration for child welfare, mental health, probation staff, and our leadership teams.
Oh, and just to add, so on the training, one of the things we hope to do in terms of cross-training is not just to help people learn about the KDA mandates and the core practice manual, but also in general. In discussing this with our steering committee, it became really clear that even just the basic mental health 101, child welfare 101, juvenile probation 101 are really needed for all of our client-facing staff to really understand what each other does. So we're going to do that internally, but we're also then going to have the consultant come in and do more specific targeted training, which again will be open. Our hope is to open it up to all the people involved, so it's not just mental health or child welfare. It will be everyone getting a similar training.
Absolutely. Sorry. Next slide, please. So here's collaborating with agencies. Some of the successes we've had is our partnership with probation. Historically, child welfare has had a great partnership with probation, as has mental health, and we've agreed to serve probation youth as part of the subclass, and it's great to have them at the table. Early on in the process, like we talked about, we had the youth voice interjected in our program development with our focus groups, and we hope to do more of that in the future. Some of the challenges that we have come up against is really learning and understanding different agency cultures, mandates, priorities, and how to work together and work through our differences. And learning how to fully implement the core practice model, values and principles in our work while maintaining our other duties and other mandates has been a bit of a challenge. And finally, I think the biggest challenge is, at least from the child welfare and mental health lens, is really learning to relinquish control and create a new culture of collaboration. We have different, while we are all serving children, we do have different frameworks and lenses from which we come to the table with, and learning to how to talk together and come up with some common goals has been a learning process. So some of our solutions, we have the creation of our steering committee, which meets once a month. We are purposefully using the core practice model and the values that are in the core practice model in our process and using it to guide us as we collaborate with one another. And we have our interdivisional committee meeting, which Colleen spoke about earlier that not only deals with pathways to well-being, successes and challenges, but also agency collaboration as a whole.
And I just wanted to add that we actually invited probation to participate in this presentation, but unfortunately they were not able to do that. But if people have questions, you can contact either Chelsea and I, and the people from probation would be happy to talk to anyone who's interested in doing that, including probation in their implementation as well. Next slide, I guess.
Next slide, please.
So next steps for us, as we've already talked about, was figuring out the cross-training. And we're going to work on sort of creating what specifically we need to do, but we're looking at cross-training, like we said, generally and also specifically for the KDA mandated services and the core practice model. We will continue to work on program evaluation and make changes as needed. We see that as a definite part of the process, and what's been nice is we've all agreed that we're receptive to this process and we're able to have these good discussions about what's working and what's not working, and there's a really nice atmosphere in terms of having that discussion, at least in our steering committee meetings, and looking for solutions. One of the things that I think would be our transition phase, if that's what we're headed for, would be to really figure out what methodology we want to have for evaluating how we're doing as a program. I know that's a big part of what the state is talking about as well. Napa County uses a palliative measures process currently for all of our mental health outcome data, and we're wondering about whether or not this is the right approach, and how do we really measure our success. So that's an area we'll be working on. And then another area that we've identified is that we really need to get more community participation. We haven't had that much involved, although there have been times when we've been able to go out and ask community members or other stakeholders what they think about what we're doing, but we really want to have a more robust process and bring them in. Especially foster youth and foster families, biological families, and parent partners, to make sure that we are actually doing what we need to be doing for the people that we serve. So those are our next steps, and there's probably a few more that we'll identify over the course of the next few months, but that's where we are now. And then the last slide has our contact information. So feel free to contact us if you have questions or suggestions. We're also open to suggestions.
Very open to suggestions.
And thank you very much.
Thanks a lot.
Great. Thank you, Colleen and Chelsea, for a really informative look at Napa County's Pathways to Wellbeing program. And we really appreciate the work you're doing with probation. I think is really great. It's great to hear that you can do that in a small county. So thank you for sharing that with us. So now we're going to turn this over to our next presenter. We're going to have Kings County present. I'm going to formally introduce Shelley Verboon and Brenda Randall, who are presenting from Kings County. So Shelley Verboon currently serves as the CPS Program Manager for Kings County Human Services Agency. She's a former CPS supervisor in Kings County, and prior to that worked for 10 years in Children's Services in Tulare County. She began working on the Kings County CFT team and the KDA program about 2 years ago. In addition, Shelley's responsibilities include the Resource Family Approval Program Pilot Project, the Quality Parenting Initiative, and numerous other child welfare service units and programs, and she facilitates the county's multidisciplinary team meetings. Shelley is a very busy woman. Also, we have Brenda Randall. Brenda has a long and distinguished career with Kings County, and she's currently the manager of the Full Service Partnership Unit under the Mental Health Services Act, and previously served as program manager and administrator of alcohol and other drug services for 15 years. At the state level, Brenda was treasurer of the County Alcohol and Drug Prevention Program Administrators Association for 7 years. She's also served for 3 years on the California Child Welfare Council. Mother of 3 and proud grandmother of 3 girls who was praying that the baby due in December 2015 is a boy. Brenda is a veteran and a retired United States Navy Reserve officer with 25 years of honorable service. So it's my pleasure to turn this over to Kings County.
Good afternoon. This is Shelley Verboon.
Good afternoon. This is Brenda Randall.
We're going to approach this in a little bit different way than Napa did, who, by the way, is very organized, and I'm very impressed. We're going to talk a little bit about Kings County and a little bit about Kings County. Kings County is located in the heart of California's rich San Joaquin Valley, and we have 1,391 square acres, with over 70% of that dedicated to agriculture. So obviously we have our primary resource in Kings County is agriculture. Kings County is unique and diverse within its boundaries. We have 3 state prisons. We also have a Lemoore Naval Air Station and a Santa Rosa Rancheria located within our county. So without being said, we have a very unique and diverse county. Partnering agencies working to serve children and families in Kings County include Child Protective Services, Behavioral Health. We have CASA, Kings County Community Action, Kingsview Mental Health, Probation, the schools, law enforcement, UCP, Parent and Me, and First 5 Commission. We are also very active with our Champions Drug and Alcohol Recovery Centers, who serve, who have 2 facilities, Hannah's House that serves mothers and children, and Samuel's House that serves males who are involved in AB 109. Prior to KDA, children were referred to mental health or substance use services as needed. So if, for instance, if we got children into the system, we did not automatically refer them for mental health services. If the foster parent or the social worker identified mental health services were needed for the child, then they would refer them to the contracted service providers. Second page, next page. Planning for KDA implementation. Behavioral health staff participated with child welfare, family builders, foster family agency, and Kingsview mental health personnel to provide services and training for Kings County Child Welfare Services, Kings County Probation Department, and Kingsview counseling staff about the wraparound program. So we kind of went about it a different way than Napa County went about it. The initial planning and implementation involved only dependent foster children. However, it has expanded to all CPS-dependent children at this point. Also, we take referrals from the schools and probation. So what happens is that behavioral health and our mental health departments are under the same umbrella but separate entities. Behavioral health contracted with Family Builders to get, which is one of our local family foster agencies, to get involved with offering our RAP services. Family Builders provided RAP coaches who work with children and who have behavioral problems, as well as children identified in the KDA subclass.
So just to expand upon that a little bit, it was the idea that because we already had a contract with Family Builders and they were already involved with us doing the RAP services, it made all the sense in the world then to, once KDA came on, to expand the services to them. So then we went back to the table with them and developed new contracts, revised contracts, and new negotiated scope of work so that we could then expand to the KDA services.
Right. So now Child Welfare refers all children upon involvement for mental health services. All children who are ages 0 to 17 are referred for mental health or ASQ assessments. Children 0 to 5 are referred to behavioral health for developmental assessments. which includes social and emotional screenings. Children who are 6 through 17 are referred to Kingsview Mental Health for a mental health screening assessment. And they are also part of the CF team when staffing cases, as well as family builders, child welfare services, behavioral health, probation. Okay. Oh, next slide. Okay, that's yours.
Okay, so
You're bringing up.
So we're going to look at the services and the roles and responsibilities. CPS refers all children for a mental health assessment, as she said, and that referral will come over to Kings County Behavioral Health, and it's depending on the age. If it's going to be the 0 to 5, of course, as she said, goes over to Behavioral Health, and then if they're older than 5, they will go over to Kingsview. She mentioned something, and that's also very unique about Kings County and our relationship with our mental health plan. Kings County is one of the last counties to actually we do not provide mental health direct services at Kings County. Our mental health plan is contracted through Kingsview, who also has an IT contract with us to provide the Medi-Cal billing services for us as well. So it makes it a very unique situation in which I don't think, I think we're the last county actually that has this model. So then they also will then, the therapist at Kingsview will then also make a determination for any KDA subclass eligibility. We also have forms, much like Napa forms, and that have been gone through the process of let's do it, and let's do it again, and then let's make it better type of a process, in which now we feel like you know, we are willing to share that form with anyone who might want to see it, but we think that it really does make an easier flow for determining what the subclass is. And then once that determination comes back, it comes back to behavioral health for us to then take that person into services. Family builders will then put that person on our review team caseload, and then at our bi-monthly meeting, twice a month, we actually have the meetings come up. They will then put that person on for review, and the members of our CFT team then will review the case and determine its appropriateness for services. Services are provided both in home and in school settings. Next slide. So the child and family team meetings for us, and this has gone through a lot of time of planning at the beginning stages, and there are a lot of times when you think that you've got everything wrapped up and you're ready to go, and something else will come up, and so as that happens, I think that that's one of the things that everyone has to do is really reevaluate as you go along with your programs. But for our child and family teams now, they are facilitated by our ICC, which is Family Builders, and that's done in collaboration with Kings County Behavioral Health Case Manager, who's assigned to one of her main projects is our RAP and our KDA kids. The meetings are held, like I said, twice a month on a regular basis, but please note that there will be cases that will come up that will require you basically to have meetings that will be we call them our special CFTs or emergency CFTs, depending on what's happening with our youth. And so even though we are scheduled for that, sometimes when you have an emergency, it just doesn't come up by calendar for us and meet our already scheduled date. So we do have special CFTs that come along. The participants that are included in our and represented at all of our CFTs will be, of course, the behavioral health program manager as well as the behavioral health case manager. We have Child Protective Services case managers, our therapists, social workers, as well as the program manager, my friend Shelley here. We see each other twice a month, if we like to or not sometimes. Probation is always at the table for any probation kids that come along. The schools are there. If we've got a child in the schools and the school needs to be at the meeting, they're always welcome, and we always inform them. Family Builders notifies all participants. They send out the CFT meeting schedule. Prior to that, we ask for any corrections to be made on those, and then once it's finalized, it's sent out to all of our representatives so that they know that their case is coming up, and that they can be there. It also sends out invitations to any of the foster parents, guardians, parents, the child, if it's applicable, and any other family member. So we make sure that the CFT is well-rounded so that when we're talking about this case, then we get all of the facts that we need. The social worker is there letting us know the improvements with the child or any issues that may be coming up. The coach from Family Builders RAP program is there in order to inform us about their interaction with the child. The schools let us know what's going on with them. And then once we get all of the information gathered, then we take the time to talk about how this is meeting our plan that's been developed by Family Builders to see if the plan is being met, to determine if we need to intensify services at that time or decrease the services depending on what's going on. Sometimes they make the referral from Family Builders or from the clinician involved with the child to do TBS services. So if they feel like the child is just not making improvements and they need more intensive care, then they would make that referral, and that's brought to the team, and the team would then say yes to that as well. Plans are tracked. Relevant family history is shown. The background for this child is shown. Mental health services, that if they were already a part of mental health, if they have an IEP, if they have a 504, no matter what it is, it's all part of their background that's shown there's a form that we have at every one of the CFTs, and that form has all of this relevant information on there. The school services, the significant support for the persons that are involved in the child's life, the agencies involved. Sometimes we even have to look at it and say, well, I think we've got too much involvement with some, too many agencies. And this is when we can see that in black and white and know that we've got sometimes too much involvement. And so then we decide what services need to back out. We talk about recent successes, any issues or problems that they're having. We discuss the strengths and we discuss the struggles, as well as what type of barriers that may be there, including cultural barriers, anything impede upon the future development or the well-being of the child that we're then discussing at that time. Also, how we're making track to reach the goals that we set for the child. Next slide. So for us, there have been many things that we've learned as Napa, and I teased them at the beginning of this and told them that we really wanted to borrow their front slide, except we needed to put a little blood on that front slide as well, because definitely through blood, sweat, and tears and a lot of collaboration, and I think of all the accomplishments and lessons learned, one of the most important thing is that as you start developing these teams, there has to be an agreed upon thought that everyone has to check their different personalities and attitudes, and all of the things that their agencies were founded upon have to be left at the door so that you can improve collaboration and partnership across the agencies and the disciplines. Otherwise, you will not have a successful program. Family Builders is an accomplishment. I've listed them because when Family Builders came on, they did not have this is being done through our system, and they also they did work though with Kingsview, and they also were part of the TBS services that they did. So we took advantage of and the opportunities that was presented with us and took a company that was already involved with both Kings County Behavioral Health and used them because it really did make sense to fold them into something that made it easier for us to work with. So they handled the Medi-Cal billing services for them through Kingsview. But as of April 1, thank God, Family Builders has now moved on to have their own electronic health system, record system. They use Anasazi, same as Kings County Behavioral Health and all of our other providers within the county. And so we have they now have a data management system. The good part of that is that we share a data system, but that also brings about some challenges where we have to make sure that you have done all of your agreements and MOUs and consents. You have to have consent using a shared data system. And I know of all of you who've ever done that know that that can be a daunting task to make sure that each one of the agencies agree to that document and then having all of the agencies a part of that. But it is something that is worthwhile doing so that you can share all of the data that you need to share, and it does not impede upon the process of the program itself. Behavioral health monitoring process for Family Builders has been enhanced now. that's a lesson learned. Once you have outside, behavioral health is ultimately responsible for this program, and having outside providers within that program means that we have to have our monitoring process looked at and reviewed and then looked at again sometimes. And you don't want to catch your program being less than what it's supposed to be by having an audit or an audit exception because the records are not being kept appropriately, because we are not on top of our monitoring process so that DHCS is happy and satisfied with it, and so that we're meeting the mandates and the criteria of KDA, because that is one of those things that when anytime you can cost the county money, you definitely want to be sure that all of your programs are following the guidelines of it. KDA joint reporting to the state is very much so a team effort, and so that monthly report, our quarterly reports, any of the reports that are due to the state, go through all of the hands of the key stakeholders, so Child Protective Services, Behavioral Health, Kingsview, and Family Builders all have a hand in providing that joint report. And one of the other accomplishments that wasn't mentioned, but I definitely don't want to miss it, is that Tina Garcia, the Deputy Director of CPS, has been on the California Child Welfare System Core Practice Model Design Committee since its inception. And she's also on the subcommittee for communications. So, and also developing a best practice guideline for child welfare departments. So we've got an upper hand in that case when we're talking about the core practice model. So when Shelley was talking earlier about all of the trainings that went on, and not only the outside trainings, but internally, we had an upper hand in being able to do that, to pass on to all of our other partnering agencies the learned experience that child welfare has brought to the table, but with Tina directly working with the core practice model. The other thing I want to make sure that I add to this is that when you're getting ready to do your meetings, make sure that you have meaningful agendized, if that's a good word, agendized meetings. You know, a lot of people have spent a lot of time in meetings, and there are a lot of meetings to attend. And we have found that as long as there's an agenda to those meetings, they really make them a lot more meaningful. They flow better. You stay on task, and you get people in at the time that you set, you know, have allotted for your meetings. And that is a good practice, I think, that all meetings need to have. And we have definitely found that it really helps us because the purpose of the meeting is met every time, and it does keep us focused. And the only last thing I want to add to that is that the forms, the process, the procedures, the protocols have all been developed. We did that through the implementation stages, but they are now at the point of we are reevaluating them. We're looking at them again. We're dusting them off. We're always looking for, and Napa, we like to quite a few things on yours, thank you. So we're always looking to improve those, and that's the other lesson learned. Reevaluation of your process and procedures and protocols will allow you to keep a I think a #1 program moving for the benefit of all of the children that we serve in our community. Next slide.
So,
with that,
yeah, if I could just add one thing that I think KDA has brought to our community and to our agency, behavioral health, mental health, child protective services, probation, schools, we didn't have a strong connection. We all worked separately in different entities. And one thing KDA has done is brought us together and made us network and work together and actually learn about each other's programs and respect each other's programs. And I personally have gotten a lot out of that. And I think it has been very beneficial to our county programs and to the KDA
beneficiaries.
Yeah, definitely.
I would definitely echo that with Shelley. We definitely have a lot of respect for one another now. And like Napa shared, learning each other's cultures, learning probation has always been noted for law enforcement, and it was really hard to, you know, for a while, you know, it's hard to imagine them having the empathy that we think we need for a lot of these cases that they have to go through. But they actually have come a long way, and I think that's been through just having them at the table from the beginning to now, and using some of those other connections for some of our other programs. You'll find that it really will open the door to benefiting you on how you collaborate for other programs that you have. Our CJTC, I feel like our Collaborative Justice Treatment Court has been enhanced by that relationship as well. So with that said, if there's any questions or anything that anyone would like to have, there's our contact information. and Shelley and I are happy to share our forms, to share any of our other knowledge. If you have any questions or anything you didn't understand, we'd be happy to make sure that is. I noticed it didn't have our phone numbers, so by all means, email us and we can provide that.
I didn't put Brenda's phone number down because her phone never works.
That or she doesn't answer, one of the two.
Great. Thank you, Brenda and Shelley, for a really good insight into Kings County's KDA program. We really appreciate that, and also, really hearing the characteristics of your county, the small population, and how you've done this really great collaboration to make this work. So at this point, we're going to open it up to questions from anybody who is listening on to the webinar. We'll be entertaining questions for the entire presentation for either county. So to ask a question, if you can go ahead and type it into the question box, which is on the right-hand side of your screen, into the dialog box, the GoToWebinar control panel, and Kelly will read the questions, and then we'll get an answer. So go ahead, Kelly.
Okay. Our first question is for Chelsea, or Napa County. What is your experience in implementing CFTMs for EFC and/or non-dependent minors?
Can you repeat that one more time? There's a lot of letters.
Yes. What is your experience in implementing CFTMs for EFC and/or non-dependent minors?
Well, because non-minor dependents have the right of first refusal because they are adults, we have offered CFTs to our non-minor dependents, and I believe all of the ones that we have offered them to have said that they would not like a CFT. In Napa County, we also hold what we call life conferences, which are meetings designed to help youth when they turn 21 be independent. So a lot of our young people believe that that is the best venue for them to talk about their goals, whether they're personal, mental health, whatever. So they're choosing to do their life conferences rather than a CFT.
And just as the mental health person, I would say like those are so well run and so well done that at times I'm not really sure what we in KDA can offer on top of what they're getting from that service. So usually they're well served in that capacity.
Great, thank you.
Okay, this one is for Shelley, or Napa County again. Can you elaborate on how you are being mindful of cultural humility, sensitivity pertaining to assessments and CFTs?
Well, okay, so of course one of the core practice model values is the diversity, is really understanding diversity and being culturally sensitive. So it's my hope that by bringing on, we have the 2 new staff coming on, both are bilingual and bicultural. So it's my hope that that will bring an element of that to this process. Also, one of the other things is we do have, mental health has another full service partnership program, which is pretty much our mental health wraparound program that primarily serves Spanish-speaking families. So that's not the only group that they serve. But the majority of their staff are also bilingual, bicultural. So we have partnered with them on several cases so that the families that are Spanish-speaking only are receiving those mental health services in that capacity, and then on top of that, we're providing the facilitation. So we actually partner with the other providers that are maybe sometimes more culturally close to the families that we serve. So we're mindful of that, and also Napa County as a whole really values diversity, so we have regular diversity training. There's a lot of information here, and we have a diversity committee in mental health, actually in the Health and Human Services Department, and we're all a part of our larger Health and Human Services. So Health and Human Services itself has placed an emphasis on helping improve our ability to serve families of different cultures and be more mindful of that. Hopefully that answers the question.
Great, thank you.
And then does either county have any data on the average cost per subclass child?
Well, I can say from Napa County, we don't, not yet. It'd be nice if we did, and I think that's one of those things we'll add to our next steps list.
I like that as one of the goals and objectives, and I'm pretty sure that before long the state will ask for it as an outcome as well. So a ditto for Kings County. We don't have that information at this point in time, but it's definitely something that we should be looking at. I like the question.
Okay, and then how are you collecting data, pen, paper, database, spreadsheets on CFTs and other KDA-related activities?
This is Kings County. So we have actually the data system. We use Anasazi in Kings County. That's part of it. We are collecting some things by spreadsheets. Unfortunately, we haven't been able to make everything electronic. It's an Excel spreadsheet that captures a lot of the data for us. But that's one of the tasks of the Recovery Support Coordinator who's in our Full Service Partnership Program and who's also assigned to the KDA RAP Kids. But we are definitely looking at how we can, that's just part of our agency-wide task improvements, is to be looking at how we can make any of our data, if we can get it from electronically, the more information we can get electronically, the better. We are always looking to make that happen. But unfortunately, at this point in time, there are still some things back by just old-fashioned Excel worksheets.
Yeah,
okay,
so sorry.
Go ahead.
Oh, I was just going to, was that for both of us or the last question? Oh, so I was just going to answer from Napa that very similar to what Kings County does is we have Anasazi, so we gather what we can through reports for Anasazi, but because not all of our kids are in our Anasazi system, because Napa County actually does have to have other counties serve our foster kids because we don't have enough foster families, so not all of our kids are in our mental health system. So Chelsea and I have to do a lot of this by hand, and then Child Welfare has developed their own internal ways to keep a database, just really kind of meet and compare it. It's not an ideal system. We can't figure out how to make our systems talk to each other yet, but I know that Lisa Murphy, who works with us, has been talking about this with the Anasazi work group statewide, just to find ways that we can simplify it. So that's a process we haven't figured out yet.
Okay. For Napa County, what is the caseload size for the PWB worker?
So at this point, we're anticipating that each of the clinicians will have about 10 cases. And of course, we're getting some really difficult cases where they're requiring a lot of time. So we're really looking at that on a regular basis to see if that's an appropriate amount. But we've kind of anticipated it to be about 10 cases per clinician.
And that's child welfare and juvenile probation.
Right, a crossover of both.
Okay, what kind of challenges occurred following implementation of CFT and referral process in terms of collaboration? And that's for both counties.
So this is Kings County again. My Deputy Director, Kelly Baker, and again, Tina Garcia, the Deputy Director of CPS, were on the beginnings from day one. They were the two that were assigned to bring KDA into Kings County. And I can tell you that there were lots of meetings, and then more meetings, and then some more. And from all that I've read, and having been, I think, the last person to come on board with this program, I can honestly say through everything that I've read, the biggest problems was, again, understanding each other's cultures. Yep. Understanding, and that's one of the things that, like Shelley said, we can appreciate now. When you get different agencies in a room together and you start talking about, you actually have a better appreciation and understanding of why they do what they do. And so you can say, okay, yeah, you know, why are you not doing it? And then you go, well, this is why, and here are our reasons. And then you go, wow, I find myself supporting a lot of the things that they have to do because I know now why. And the same thing with them. You know, we would love to be able to take on everyone and do everything and make things better for every child we touch, but that's impossible, and there's reasons why a lot of times. So being able to definitely there was a lot of, and I'm not joking when I say take the slide and throw some blood out there. There was a lot of blood, sweat, and tears after the implementation. But that's where you go back and reevaluate, and then you home in on, you know, the real thing that we're there to do is to serve our youth and do a better job of our children and make them, you know, keep them well and make sure that they are, you know, getting all the services that we're required to give and then some. And so I think that this is what has happened with us. That genuine appreciation for agencies that are no longer siloed in not only what we do and what our basic mission is, but how we then lend a hand to all of our partners. to make theirs better. No one is now saying, well, that's your child, you pay for it, you know, or no, it's our child. This is a community thing. This is a agency, Kings County-wide agency thing, and all of us are here to make things better.
Okay. There's a second part to that question that says, how do you keep it going?
By setting regularly scheduled meetings.
They used to be a half a day, and now they're a full day.
And we have the ICC and Family Builders keeps account of, at the end of every meeting, we say, when is that child coming back before the review team again? And so they bring, that's why the calendar is set, and that's why it comes out when it does and lets us remind us, here it comes, here's the kids that are up for review at this time, and here's, you know, what's going to be. And then if there's somebody that's been missed or there needs to be a new add-on, then we let them know when that comes out. That's our reminder cue to give them any feedback, and then they bring it back. But knowing that we're going to meet every other Tuesday beginning at 9:30, and we are scheduled from 9:30 to 4, we know we've got to be there. And so if I can't be there or if Shelly can't be there, someone from our agency is.
Okay, and the next...
Oh, go ahead.
I was just going to say, for Napa County, we've experienced a lot of the same bumps in the road that Kings County has, and it really comes down to role clarification and communication. So what we have found that is working is, again, regularly scheduled meetings to really talk about when an issue has come up, to process it as a group and talk about how we could, what works in that scenario and what didn't, and what next steps we could take to not be in having some bad collaboration, I guess. And that has worked helpful as we've had our hiccups in along the way.
Yeah, and I would just add, like, so we have had staff had to work out a lot of these issues in the process. So like my one staff who's been active, Mario, has worked directly with child welfare staff when these bumps happen. And so as a supervisor, I just continue to support that process. So, and I know Chelsea does as well. And then when we need to, we get together and talk as well to figure out how to help support resolving any of the bumps that we or the challenges that we encounter.
I want to also add to, this is Kings County again, I just want to also add, and I think that you would be surprised to hear this, but we had a case, and it was one of those emergency CFTs that we had, I told you about, that they do come up, and to show you how far we've come, everyone that we said, you know, you need to be here, here's this child, you know, we've got a case, we need to staff this, everyone showed up. It's not been not one meeting where everyone has not showed up. Probation is throwing out possibly, you know, what do we do for this child? What have we already done? What's different? What do we need to do? We had a social worker who made 106 phone calls for one child for placement. Always because we don't have any facilities in Kings County. So when you have people trying to even look up other places, okay, here's some other ideas, here's some other places to do. Every agency at the table was doing that. It tells you we've come a long way. And then that's the type of collaboration and partnership we have now.
Okay, that's great.
Sorry, if I could add just one more thing. This is Colleen from mental health. This is a very mental health thing to say, but I really try to keep going back to the fact that everyone actually has the child's best interest at heart. So we're all coming from that same mindset. And so a lot of times it's just a matter of sitting back and remembering that even if we may not agree with what's coming, you know, at us from different areas, or, you know, people are bringing in different perspectives, ultimately everyone has the same exact desired outcome, which is that the family and the youth are, they benefit from what we're doing. So it's just keeping that in the back of your mind, and I just encourage my staff to do that, and I know that child welfare does the same, and probation. So.
Okay, for Napa County, can you talk more about how confidentiality is being handled currently? Specifically, how do you communicate CFT minutes to team members? Other communication between social workers and mental health staff about clients while maintaining HIPAA guidelines?
So at the beginning, this is Chelsea from Child Welfare. At the beginning of every case, every child that comes into foster care gets a universal mental health screening. And at that time, releases are signed, so child welfare and mental health can talk. And that is for the life of the dependency case. So if a young person is determined to be subclass eligible and is in the Pathways to Wellbeing program, that helps facilitate having those conversations with mental health around those services. And then Colleen can speak a little bit more about the other areas of HIPAA regulations.
Yeah, so from the mental health perspective, we do get the releases signed. Currently, that's what we do for Napa County, but in many ways, one of the things that KDA has brought to our county is the re-examination of that process. And so we've actually worked with our county council and in leadership to try and figure out what we really need to do, where are the areas where we have to have releases, where we don't. So it's a process we're really looking at and creating agreements. But currently, to make sure that we are respecting confidentiality, we are making sure that there are releases signed for everybody who attends the CFT. That's a part of the process. As Chelsea said, everyone's signing releases when they come in the door, and then we in mental health will monitor to make sure they're all current and continue to be accurate. So, but it is a process, and we will continue to work on it. And we have actually looked to some of the other counties and some of the other webinars who've had that subject come up and to see what other people are doing. So we're also interested in suggestions on that.
Okay, next question. We know that electronic care coordination can improve the safety net for children and youth. So I'm interested in the electronic health records portion that you've discussed. What was the name of the system that Family Builders is utilizing? And just to clarify, CPS workers share access with the FFA to the data management system, and do the youth also have access to their health information?
So this is Kings County, Brenda. Yes, it is. It's Anasazi. It's the data management system, and and because Kings County, as well as all of our providers, are using the same data management system, we have a shared consent form as well that everyone has to sign when they start with intake in order to go through services. Matter of fact, it actually says in order for them to receive services from anyone in Kings County, they have to agree to this because we have a shared data management system. So therefore, I can see the records for, as a program manager, I can see the records for one of the other providers. Now, do I have a need to know? No. So if it's something that's sequestered out, then there are records that can be sequestered. But as far as from the onset of someone coming into services, they have to sign that consent. And it's another, like Napa, it went through county council, it went through all the gyrations of being HIPAA compliant, so that we knew that we would not have any problems. So the releases of information are signed right off the bat, and everyone involved in the process is included in that consent form for the electronic health records. And as far as, I'm sorry, and you also asked about the youth, are they have privy to their records? Was that the question?
Yes. Do they have access to their records?
The guardian or the adult can have it. If it's a youth who's emancipated, then yes, they could also ask for their records, but it's not for a child.
Okay. Next question, what variables are being tracked on the Excel spreadsheet? I guess that refers back to the what data is being collected question.
When I was going to say, do you have one of the spreadsheets? I'm going to think about this because I don't have one right here in front of me. But I think like that the eligible. When do we get the referral? How long, so we can track how long it takes from the onset of the referral through the system to when they actually are taken on as a case. When there are other variables on that. I'm definitely able to share that, but I'm trying to remember right offhand all of those things. But there are other things that we cannot collect. Yes, if they're KDA, right? Do they belong to the KDA subclass or not? So there's a check for that. So that we have, at any time, we can tell you how many RAP kids we have totally and how many belong to the subclass. Thank you. So we include their name, their date of birth, their age and gender, their ethnicity. It's a demographics for that, the address and stuff, which a lot of that can also come out. But it also includes what school they're involved with, if they have a RAP coach or a TBS coach, who that person is. If they have a caretaker, then who that caretaker might be. That's the information that's on there.
Okay. Next question is for Napa. How do you determine open probation cases to be eligible for subclass if they don't have a current open child welfare case?
So this is Colleen, and Chelsea can help me. So I'm not sure what all the thinking that went into the initial agreement that probation use would be involved, but my understanding is that we view them as being a part of the system because they're in probation. And so we apply the same criteria. So they need to meet the basic subclass criteria. So they have to be on Medi-Cal. They have to have a qualifying mental health diagnosis, which is, we'll do the assessment to determine that. They also have to meet the other factors like being at risk of losing a placement. They could be in foster care, because there are some probation youth who are in foster care, but they could be at risk of being sent to a group home or I think hospitalization as well. So, so we give them the same exact eligibility criteria form that we give to child welfare and ask for them to complete that so we get that information on the youth.
Yeah, we're not really looking to see if they're a dependent or not. That doesn't make them eligible or ineligible in our county. It's really about being in foster care or at risk of imminent placement in foster care, and at that point, if they meet the rest of the criteria, then they would be eligible for to be in the Pathways to Wellbeing program.
The next question is for, let's see, are you aware of any KDA trainings or conferences upcoming?
And so this is Kim. I'll go ahead and answer that. So from a statewide perspective, the statewide learning collaborative that's been going on for the last year and a half is having its final convening on August 6th, and that's for counties that have been involved in the learning collaborative and all the other counties too. And that's something that CalSWEC is organizing. It's limited to just a few participants per county, but that's something that's coming up. CIBHS will be planning some trainings for the upcoming fiscal year. So whomever had that question, if you want to send an email to me, my email address is at the slide. I'm Kim Mayer, and I'd be happy to send you some resources for that.
Okay, the next question is, who makes up Family Builders?
Who makes up Family Builders?
Correct.
Okay, Family Builders is an agency that is made up of RAP coaches. They also do as an FFA.
Yeah, they're a family foster agency. They began as a family foster agency for foster care or private placement of foster children. We decided to contract with them and for the RAP program because they were initiating a program for their MFT interns, and we used those interns as our RAP coaches. And so that's kind of how that evolved, that we could get, it was a win-win situation. We could get people who were being trained to be therapists, and in turn their therapists could get hours. Does that answer your question?
Yes. Let's see. I do have a request for Napa's confidentiality release, and then somebody else asked whether aren't the releases signed for the or they expire, sorry, after 1 year.
Yeah, this is Colleen. Be happy to provide that. I guess Kim, you can let us know how we can maybe get that to you.
Sure, just send it to me.
Yeah, so we had a long conversation about the expiration date. So typically mental health practices the 1 year expiration date, but for the initial releases, we worked with County Council and got an agreement for till the case is dismissed. So we're still ironing out all the details around that, but initially we're accepting, as I understand it, we're accepting that it has it's a valid release until the case is dismissed from child welfare.
And that just allows child welfare to talk to mental health and give the referral over to mental health, and then from there mental health a pile of different types of releases for various people. So it really just is, that initial release really is just so we can communicate at the beginning rather than having to wait to find parents or find GALs to get services moving quickly.
Great. And we have two final questions here.
How are you working with KDA youth in out-of-county placement? How are CFTs conducted when minors are identified as a subclass and in and out of county placement?
Oh, what a question.
Tell by our silence.
Well, this is Colleen. I'll just say, you know, like I've asked the question in the KDA tech calls in the past. It's a very difficult problem because I'm not sure how it is for King County, but for us, we do have a lot of kids out of county in foster care. So initially, we weren't necessarily serving them. I think we're evolving to take more of a role in that, but we haven't really figured it out. So that's a huge question. We'd love some guidance on that as well, but you know, determining who's responsible to follow up. So we're kind of we have some kids where there's a high acuity, so we are staying involved even if they are out of county, and just now collaborating with other partners in other counties to try and make sure they're getting the services and still trying to offer CFTs, but it's very difficult.
Yeah, we usually will see them within the Tri-County area, which is Tulare County, Fresno County. It's less than an hour drive. But other than that, we really haven't been serving that population yet either.
Great, thank you.
Okay, the next question is a follow-up question. Do you bill ICC and IHBS for the probation cases if they don't have an open child welfare case?
For this Napa County, yes, we do.
Kings County as well.
Last question. Can you describe how you collaborate with group home providers if KDA used in group home to prevent duplication of services and billing?
In Napa County, we don't have any local group homes, so our kids that are in group homes are out of county, and as Colleen mentioned, we still haven't quite figured out how to work with our out-of-county young people.
And just to add, this is Colleen, so what might happen if we have kids that are placed in group homes, mostly that's coming through probation at this point. Child welfare isn't necessarily placing that many kids in group homes. But we as mental health can stay involved, but we just have to honor the 30-day lockout for the ICC services. So we'll provide regular kind of targeted case management services until we're at the transition point, and then we sort of restart the ICC process. That's how we've done that, but we're hoping for more guidance as well on how to do those kinds of things.
Our group home kids are all out of county also, and we have not been serving them as of yet. We're still working on that.
Great. Well, thank you all very much. I want to thank all of you for your questions and answers, and I want to thank our presenters again, Colleen and Chelsea from Napa, and Brenda and Shelley from Kings County for really informative and really interesting presentations. We want to invite you to our next webinar, which is next week on June 30th, which is also another small county perspective on implementing KDA. And we are at the end of our time, so thank you in the audience for attending. Once again, we encourage you to take a few minutes to share your feedback as you exit the session. With that, we will conclude our broadcast, and thank you again for joining us.
Thank you.